Hello, everybody. Welcome. Thank you so much for joining this webinar. I'd like to start right now at 9 a.m. EST, just to make sure that we have time for everyone to get their questions in and for our speakers to answer any questions that we might have. My name is Samantha Serrano. I am the Associate Director of Science Communications at the One Health Trust. And I'm very happy that everyone can join us today. Hello, Professor Baum. Thank you for joining us. We are very honored to have the three experts we have today to talk about this ongoing this ongoing crisis. It's a really important discussion to have right now. Mpox is a One Health crisis. It's a zoonotic disease with potential, for a pandemic that's quickly evolving, and it's heavily impacted by issues like social disparities, conflict, migration and displacement, vaccine equity, and more. And this is, all against a backdrop of major shifts and losses in global health funding. This issue, I think, has lost a lot of attention, and we'd really like to bring it back into focus. I'm really honored to bring together these three experts that can speak to the many facets of this ever-changing crisis. Unfortunately, Dr. Ngashi Ngongo had a scheduling conflict, and he's going to be unable to speak today, but we're really happy to have Professor Yap Baum II take his place and speak on behalf of Africa CDC. Before we get into questions, I just want to introduce our experts. Our first expert, Professor Yap Baum II, is a Deputy Incident Manager for the Continental Mpox Response at Africa CDC. He's also the former Executive Director of the Institut Pasteur of Bangui. He's a public health expert. He previously represented Epicenter, which is MSF's research arm, and he led Cameroon's COVID-19 operations. His work spans tuberculosis, malaria, HIV, Ebola, and COVID-19, alongside teaching public health and microbiology across Africa. He's passionate about equity and African-led research. He co-founded several initiatives, including IDOCTA, HS4 Health, and an AI-powered platform called The Village. He holds degrees in engineering. He holds an MSc and a PhD in microbiology, an MPH in epidemiology, and an MBA in entrepreneurship. So welcome, Dr. Baum. Our second expert is Dr. Alana Ibarra, and she is an infectious disease malaria advisor to MSF Amsterdam and an infectious disease consultant at Imperial College Healthcare NHS Trust in London. She's an honorary senior clinical lecturer at Imperial College London in infectious diseases, where she's undertaking a research fellowship on AMR and displacement. She's worked in a number of humanitarian settings, including in outbreaks for emerging and re-emerging infectious diseases, particularly in conflict-affected settings. And then we have Mr. Nodar Kipchitsi. He is a senior research analyst at the One Health Trust. He is a PhD student in epidemiology at Columbia University Mailman School of Public Health and a T32 pre-doctoral fellow in the Global HIV Implementation Science Training Program funded by the National Institute of Allergy and Infectious Diseases. His research centers on questions of disease persistence, mobility, and vaccine effectiveness using mathematical, statistical, spatial, and agent-based models. We're going to start out with 2 rounds of questions for each of the speakers. And then after that, we will have time to take questions. So if you do have questions throughout the talks and throughout the answers, please write them in the chat and we'll be sure to get to them. The first question is actually for Mr. Kipchitsi. We just like to sort of build a panoramic view of what's been happening recently with Mpox, just to better understand the epidemiology of Mpox and the different recent outbreaks. Can you speak a little about the 22 Mpox outbreak that sort of brought global attention back to Mpox? Tell us a little bit about that, and what is the difference between that outbreak and the current outbreak we're experiencing now since 2024?
Yeah, those are fantastic questions. And I think I would even start by saying that the two recent outbreaks are very different from historical Mpox outbreaks, which also kind of brought a lot of attention to even the 2022 outbreak, because the epidemiology and who's being affected and where is being affected really shifted from our understanding of Mpox. Between the 2022 Mpox outbreak, which is still ongoing, contrast to the 2024 outbreak, which was largely localized in sub-Saharan Africa, are also vastly different in terms of who was getting infected, how it was being transmitted, and then obviously geographically where it's been spreading. The 2022 outbreak was primarily driven by Clade IIb Mpox. So if you want to think of clades as kind of like cousins of very similar viruses, that's, I think, the best way of explaining clades. I'm still trying to figure out the best way to describe the differences. But basically, Clade IIb was really driving the 2022 outbreak. As of now, it's spread across 110 countries with at least 100,000, maybe 120,000 from the most recent reports of confirmed cases, not even suspected cases. If we look at who's being affected both globally and even here in the US, it's largely driven by sexual transmission, either via skin-to-skin contact or the exchange of bodily fluids, largely affecting gay, bisexual, or other men who have sex with men for the data that we do have available. And then also affecting men really between the ages of 18 to 49. And as I mentioned previously, we're still having cases that continue to spread and emerge globally, even in the US. Even though it's largely died down from kind of this outbreak response period, we're still having as many as 200 cases per month nationally, which is still quite high for something that's not really endemic to America. And I contrasted that with the 2024, so WHO redeclared Mpox a public health emergency of international concern on the heels of Africa CDC declaring it a continental health emergency. And this one was primarily driven by Clade I Mpox, and this is really a mix. It's much more complicated in terms of who's being affected and how it's being transmitted. It's a real mix of both sexual and non-sexual transmission for data that we do have in terms of potential routes of exposure. It primarily, at least we believe, to have started from the Democratic Republic of Congo. That's kind of where the first cases were emerging. And in terms of the age distribution, even if we just focus within the Democratic Republic of Congo, it really depends on the region that you're kind of focusing on. In certain parts, it's really primarily affecting younger school-age children. But if you look at places like in the south of the Democratic Republic of Congo, it's really affecting, much more similar to the Clade IIb outbreak adults. And then it's also obviously spread to surrounding countries, where some countries, at least now, are starting to see kind of a wind down of the outbreak, but other countries are also seeing a surge of new cases as well. And it's also spreading globally, maybe not at the same speed as the Clade IIb outbreak, but we are seeing cases of importation globally. I think just as of this month, we saw a few cases in China, which was really alarming. What was most alarming, it's also, again, affecting the GB-MSM community in terms of the cases abroad. And so really just comparing the two outbreaks, really we're focusing on how it's being transmitted, who's being affected, and then where the outbreaks are situated.
Thank you so much, Mr. Kipchidze. Recently, just this last month, we had a case of Clade I here in Brazil, where I'm based. So it's definitely spreading globally. And it's really important to pay attention to that as well. The next question is for Professor Bohm. What's happening? Can you tell us what's happening on the ground in DRC with the current outbreak? Who's being most affected? What are the local government responses, Africa CDC response, and healthcare system responses in general? Can you speak a little bit to that?
Yes, sure. Thank you, Samantha, for the question, but also for the invitation, and thank you, Noda, for setting the the scene. But before going straight to DRC, just to highlight that the current outbreak is exposing 24 out of the 54 African countries. So half of the countries are currently exposed to the Mpox outbreak. That's why the public health emergency has been expanded, as we do speak, 17 countries that currently have some active case. So what is happening, as we see, it's the number of cases are around 2,000 cases per week, which is quite important in terms of suspected case. But now when we go to the confirmed case, we are around 500 per week. Now, when we look at what is happening now to what was happening 6 months ago, we see a kind of decline, especially in the confirmed case, though the suspected case are increasing. And I will go back to your question right now on what is actually happening and how we do response. So after 6 months after we declared the facts, we ended the first plan. So now we are in the new plan, which is focusing on intensification, integration, and legacy. So how these outbreaks could be taken as an opportunity to strengthen the health system. And by doing that, we deploy community healthcare workers, 3,000 in DRC, which remain the epicenter, in Uganda, which is the second most affected country, and Burundi. We deploy all those healthcare workers so that they are the ones supporting the countries in the active tracing. What we mean by that is that we need people who can go door to door, look for patient, and once they have any patient, they do the investigation to see what are the people who are around that case so that they can have access to sample testing, through sample collection, they can have access to vaccination, all the measures that need to happen around the different case. So that is the key part of the strategy, which goes together with the vaccination. The third part that is being implemented in DRC and in other countries is the decentralization of the laboratories. We are coming from a place where we could have maybe 1 month, 2 months, even 2 months for some patient between the time their sample are collected to the time they receive the result. And you imagine into an outbreak, that is not possible. So therefore, we push the establishment of laboratory capacity in every different hotspot zone so that we reduce the time between the sample collection, the testing, and therefore we can have a response that is aligned to the challenge. So we have the surveillance, I mentioned with the community healthcare workers, we have the vaccination that is being scaled up, and then we have the testing. But the critical point in DRC is that this is also the country that is affected by the humanitarian crisis. In the eastern part of DRC, which is also the place where you have the highest number of cases, where you also have the outbreak of measles, you also have the outbreak of cholera. So you have a place where you have an important number of other outbreaks. You have a humanitarian crisis, and that's also where you have the Mpox. So that pushed us to have an integrated approach together with all the different partners, maybe to highlight or to mention that the IMST is a platform. This is co-led by Africa CDC and WHO with 28 partners, including Gavi, UNICEF, MSF, and many others. So the idea now is to really take the strengths of all those partners where other people cannot have access. That's where MSF, for example, can have access to support the case management and so on. UNICEF can support on the vaccinations. So this is currently where we are moving. Going back to the North and South Kivu, because that's where we have the highest burden in DRC, and provide all the different pillars that I've mentioned, the surveillance, the vaccination, and the decentralization of the laboratory. I will stop from there.
Thank you so much, Professor Bong. Yeah, it's amazing to see the response that has happened, and it's great to see the partnerships that have been formed as well. Dr. Abada, I'm wondering if you can speak a bit to MSFs and the humanitarian response in the current outbreak. What sorts of vulnerabilities are you seeing, and how are those being addressed?
So thank you very much, Samantha, and to the One Health Trust for inviting me to speak today. So in terms of the humanitarian response from MSF, I would say it's quite wide-ranging and responsive to the needs in the different areas and the different countries related to the degree of risk and the number of cases being seen. So for example, if there are countries where there are small numbers of patients, but are at risk or have suspected cases, we've been supporting our teams and the local stakeholders in terms of preparedness, making sure they've got the correct pathway should they have a suspected case, know how to test, know how to collaborate with the local healthcare authorities. However, we have also responded in a number of different parts of the DRC, which, as we've heard, is among the most affected by far of the countries with the Clade Ib in particular, but also the 2024 outbreak in general, but also surrounding countries like Burundi. So we had a response in Bujumbura. And if we look at the DRC, so Professor Yap has already highlighted just how vulnerable the eastern part of the DRC is. So MSF Amsterdam and other sections of MSF were already active in both North and South Kivu. And this is really important because South Kivu was where the first cases of 1B were identified, and I think that was around a few months ago now. And this is where we have potentially the largest number of patients presenting to the different health facilities. So in terms of the response, we have worked in a number of different pillars. Of course, we're part of the IMST and worked very closely with the different stakeholders, but also very importantly with the local health authorities and the Ministry of Health to ensure that we're responsive to patients' needs. As Professor Yap has rightly highlighted, this is also an area of great insecurity, conflict, forced displacement, other outbreaks, malnutrition, very sadly, and also an area that's vulnerable to other emerging infectious diseases. So we've responded to this by firstly supporting, for example, the stable healthcare facilities, so the Mpox treatment centres, making sure that they are safe and accessible for patients, and making sure that our care for patients is patient-centred and patient-focused, and that the correct pathways are in place with the correct training for our staff and the staff that we work with in place to ensure safe care for our patients, but also for them, because remember, healthcare workers themselves are also one of the important risk groups, as we have seen with the previous outbreaks as well. And we've supported with a number of other pillars. So, for example, we've supported surveillance activities, testing activities, contact tracing, and also vaccination planning, which of course is a really important aspect of prevention, particularly for the most vulnerable. And then the other things that we have done, and this becomes really important, and again, it touches on what Professor Yap has said. We strengthened our community engagement and our health promotion activities because, and what's important about the latest clades or latest outbreaks that we are seeing, is we have shifted compared to other outbreaks from a predominantly zoonotic transmission, so animals to humans, to human transmission. This is sadly something that has sustained the outbreak, and also there are different risk groups where this Mpox may have spread more readily. And of course, you asked me about vulnerable communities. Among the most vulnerable of our populations are, of course, children and pregnant women, so people who may be in close contact with one another for a variety of different reasons. And then the other thing we have also supported with, and this is really important both for our inpatients and our outpatients in terms of MHPSS and mental health and psychosocial support, particularly where there are vulnerabilities for the populations that we are serving. So in terms of vulnerabilities, I've said that children particularly under 5 are very vulnerable. They've been affected differently by different clades and at different times in the outbreaks and how we have tracked it. But it's really important to understand that children hold the greatest mortality, and particularly the very young, so children under 1 year old. And this becomes really important because if you think about the Clade IIb outbreak that affected many countries in the world from 2022 onwards, there were very few neonates and children in that initial outbreak because of the modes of transmission the populations affected. Whereas in this outbreak, we did see a greater number of children. However, we didn't have the same level of experience, and I say that as a global community, not just as MSF, in terms of optimal care, in terms of treatment for neonates, what may or may not work for neonates, what is the best advice that we can give women in terms of breastfeeding. And that takes me on to other at-risk groups. So for example, people with co-infections or any other form of immunosuppression. So patients with HIV and very low CD4 counts can have potentially very severe disease. And also as an aside, we think they probably shed virus for longer, and therefore they may be at risk of also increased transmission for the people looking after them in these settings. Women who are pregnant, we still need a lot more data around that. Some evidence suggests that there are poor outcomes, whereas other evidence suggests that perhaps they're not as affected as we think. But the case series and the data that we look at for pregnant women remain not as optimal in terms of needing the decisions to make. And of course, the other vulnerability becomes other things which affect children with Mpox. So for example, malnutrition is another important risk factor for morbidity and inpatient stays, and also how we can support patients, particularly if their gastrointestinal tract is affected. And so as MSF, we have worked very particularly with the local stakeholders to ensure that the best care is available to patients and communities in this setting, particularly targeting the most vulnerable in these settings.
Thank you so much, Dr. Avada. It's good to see that the response is multifaceted from both sides. The next question is for Mr. Kipchidze. We have to, for World Immunization Week, as well as for the man who has vaccine saved lives as his background. I need to ask a question about vaccine distribution for controlling these outbreaks. Can you speak a little bit about what that looks like? And can you tell us a little bit about the 2022 campaigns in the US for vaccine distribution, and how that can sort of, help us learn about effectiveness and things like that. And then I'd really like to know what's needed for equitable and efficient distribution in the areas and populations at risk in this current major outbreak.
Yeah, it's a fantastic question, or questions, I should say. And I would start off by saying, unfortunately, we see kind of the repeating of past mistakes, I'll say, with like the COVID-19 being the most recent example, both in just kind of the global distribution of vaccines, but even just kind of local vaccine responses, and thinking about who wants to get vaccinated, and if they're not getting vaccinated, figuring out strategies to really reach out to those communities that are effective. So if we look at the US campaign or the vaccine campaign in the United States, what we saw was, unfortunately, it was a little slow going at first, and largely that was due to kind of stockpile constraints. And so for a time being, they kind of shifted to somewhat of a dose sparing strategy. So the mode of the way was people would get inoculated was slightly changed just to kind of increase the number of available doses. I think there was even at times maybe increasing the length of time between the first and the second dose, but that stockpile constraints largely kind of dissipated by, I would say, October of 2022. And so in terms of people who wanted to get vaccinated, eventually got vaccinated, I would say now, in terms of demand, it's pretty much stagnant. Like we don't see huge proportions of the population getting vaccinated again in terms of the affected populations. What we really see is that, at least in the US, in terms of who was getting affected, so almost 2/3 of cases are primarily affecting Black, African American, Hispanic, and Latinx men. But they unfortunately made up, less than 1/3 of vaccine recipients. And this isn't necessarily surprising. As I mentioned already, COVID-19 was a really recent example of, again, of who wants to get vaccinated. I mean, obviously vaccine hesitancy is so complex and definitely something that could take up more than the time of this webinar in terms of understanding like what's driving it, and it's so context specific. So in the US, a lot of it has to do with structural racism, historical determinants of health, thinking about access to vaccines and how things like redlining, historical redlining can also drive access to vaccines. Because there are even people who might want to get vaccinated, but just either are too far away, don't have time to take off from work to get vaccinated. So there's just things we have to really think about. Contrasting that to the 2024 outbreak, very much different in terms of access to vaccines. I believe it was either WHO or Africa CDC that initially estimated that 10 million doses would be needed in terms of this response, and perhaps that's maybe even increased. I haven't read if there are any changes to those estimates. I know at one point there was at least 5 million doses that were committed through the access and allocation mechanism, the AAM, which was really a mix of support from a few countries, including the US. And I know we're going to talk about changes to the funding landscape, so I'll save some of that for our next speaker. But just thinking about just even the most current administration and whether that might change in terms of those commitments. I think in reality, I believe, and maybe Professor Warren can correct me, we've distributed maybe about 1 million doses, maybe just under 1 million doses. But again, thinking about who's getting infected. So if you remember kind of when I was talking about the epidemiology, as well as some of the other speakers of who's getting affected, for example, in places like the Democratic Republic of Congo, right? A lot of children, school-age children are getting affected. But the vaccine that's primarily being used for this response, as well as the 2022 response, which was the MVA-BN vaccine, was not initially approved for school-age children, but we recently got pre-approval for the vaccine. It was either earlier this year, or perhaps late last year. And so that's been at least a positive in terms of vaccinating populations kind of most at risk, especially in terms of complications related to Mpox, as well as mortality. But again, repeating same mistakes where countries that have access to the vaccines, we're essentially hoarding vaccines, and we're not really thinking about how can we be most equitable in the distribution of vaccines and providing them to countries that really need them at this point.
Thank you so much, Mr. Kipchidze. Professor Yap, I wonder, as Nodar mentioned, if you could address these shifts in global health funding and how they maybe have impacted the current Mpox outbreak response. What do cuts mean for vaccine distribution, healthcare infrastructure, and disease surveillance?
Yes, thank you, Samantha. But maybe if you allow me, before jumping into that, I will just follow up on the issue of vaccination, just to highlight that the different partners, UNICEF, Gavi, ERA, WHO, and of course, Africa CDC, have made a fantastic job on the delivery of about 1 million or more than 1 million doses of vaccine, MVA-BN, in 10 African countries. So the vaccination is going on. There is a lot of need for the population, so there is no issue of vaccine hesitancy. But the plan that we have, and I'm responding to Nored, is that we expect 6.4 million doses of vaccine to be administered in the continent. And that is to achieve two things. One, to control the outbreak, which is due to the Clade Ib, with the sexual transmission and so on. And the other one, in country where the Clade Ia is endemic, country or region, at least to reduce by half the burden. So we are still far from getting the 6.4 million. So as he already mentioned, that will be an issue of equity to ensure that the vaccines are available where they are needed. And that makes the transition to the impact of the USG freeze and cuts, because this is really the crisis within the crisis. As for the vaccination is concerned, 800,000 doses of vaccine were to be provided by the US. So there are conversations ongoing so that we can have some waiver, and we can say that some of those are successful, where some those that were frozen now are being sent to countries, and then we keep on the discussion with them. But to go back, the budget, the pledge for the response was 1.1 billion US dollar, and the US has pledged 500 million of these total amounts. So while a large amount of what has been pledged has been disbursed, the remaining has come at the time of the cuts. And this has a tremendous impact at different levels of the response. The first one I mentioned, the vaccination, some of the doses were not available at some point. The waiver are ongoing, and we hope that we'll be able to recover all of them and on time, because they need to be there on time. They need to reach the country where they can still be used. The second point is really on the surveillance and the laboratory. The sample collection and the sample transportation in many countries, in DRC, in Uganda, in Burundi, quite a number of them were relying on NGOs like FHA 360, Village Health Team, and so on. And those organizations was heavily supported by the US aid. So when that stopped, it also means that all those human resources that were in the field collecting and transporting the sample did not have motivation, incentive. So in a country like DRC, we have a testing coverage, which is around 24%. What does it mean? It means that out of 10 persons that have the symptom of Mpox, we call them suspected case, only 2 or 3 will have their sample reach the laboratory. And this is a big challenge because the sample are not collected, the sample are not transported, which means that what we are seeing might be just the tip of the iceberg. So those are some of the impact, but also one of the key focus was and still is the decentralization of the laboratory. And part of it was quite heavily supported by the US government and the other organization around. However, you know, it's been said, never lose the opportunity of a good crisis. So the countries, Africa CDC and other partners, are working toward changing the mindset. First, carry on the discussion with the US government. A week ago, the DG of Africa CDC and the leadership of IMST was at the spring meeting in Washington, DC, to discuss with the IMF, the World Bank, and all the Ministers of Finance to see how we can change, we can address the crisis. A month before, the discussion was going on with the US government. So that's the first part. On the other part, we've launched the Africa Financing New Era, where we are looking at 3 pillars. The first one, increase the domestic funding. And it's been realized. The African countries have agreed 20 years ago during the Abuja Declaration to spend at least 15% of the GDP or investment in health. So this has not been happening. Only 2 or 3 countries have been doing that. So now it's a big push. And we were happy that last week, the president of Angola have pledged 5 million to Africa CDC to support the response to those outbreaks. So we are moving. The second pillar is really the alternative or innovative financing. How can we tap on the diaspora bonds? How can we tap on the etiquette so that we can also harness a bit of that money to invest in healthcare and the response to outbreak? And the third one, not the least, is the blended financing, the public-private partnership. So those initiatives have been, let's say, accelerated, catalyzed by the crisis. So yes, we have a crisis. Yeah, it's critical. Conversation is ongoing so that we can mitigate the impact in the response. But in the meantime, we are taking advantage to have champions so that we can have local resources to be more autonomous and, let's say, more independent, because this cut has highlighted an important dependence in both sides, while what we are looking at is really the interdependence, because what is happening in Africa with Mpox, at some point we have those mutations and they might go back, and like we have the Mpox outbreak in 2022, who knows if we won't have another mutation that will spread globally. So it's really not an aid that is needed, but an investment that is definitely needed to ensure that we are all safe. Thank you.
Thank you so much, Professor Yap. Very well said. Dr. Abada, we know that there's large refugee populations and populations of displaced people in the regions that are most affected by Mpox. We know that these are vulnerable populations to infection. How has this growing displacement of people and growing refugee populations due to conflict, climate change and economic disparities impacted the spread of in response to Mpox outbreaks and even other outbreaks. And how can aid institutions and other stakeholders adapt with these major shifts in funding availability and, really a growing rhetoric and policies that are stigmatizing refugees and displaced people, and also Mpox. Can you speak a bit to that?
Thank you, Samantha, for the question. So many of these situations, you won't see one emerging or re-emerging infection acting on its own. It's often in a setting where there are multiple other confounders and disasters. And you've mentioned conflict, climate, and sadly the forced displacement that we see in terms of these impacts. What does that mean in terms of our response? It makes it incredibly difficult. We have important pillars, as we have heard, around prevention. That includes vaccination, that includes health promotion, that includes different aspects of infection prevention and control. However, this becomes increasingly challenging when you have a setting of increased conflict and forced displacement. And that's for a whole variety of reasons. So when you have insecurity, patients may not present in a timely manner because they have to prioritize many other things. Healthcare access may become increasingly difficult. There may also be a lack of trust in the health services that are being provided, given people are being moved from areas that may be familiar with the health system and the healthcare services to an area where they are less familiar. In addition, and very sadly, the eastern parts of the DRC are very affected by massive internal displacement. And I always remind people that internal displacement forms the majority of people who've been forced from their home, not just as refugees, but internally displaced within their own country borders. And very sadly, many of them may end up in tented settlements where there is significant overcrowding. If you think back to our Mpox response in high-income settings, we were trying to say to people to try and isolate at home if that was at all possible. Of course, in a setting of forced displacement where many people share a tent, where water and sanitation are scarce and poorly provided, there is a risk of increased spread within these settings, including from adults to children and vice versa, or people mixing in such settings. So in that sense, conflict and the other confounders have profound impacts on our ability to prevent transmission. And beyond preventing transmission is notwithstanding the difficulties in accessing tests in the DRC, but it's also our ability to do surveillance in real time, monitor for areas where there are outbreaks or increasing cases in different districts or regions, and therefore intensify our activities in those settings. Because for many of our staff at one point from the Mpox treatment center in Uvira in South Kivu, it wouldn't have been possible for them to go out into the community given the levels of insecurity that were surrounding these areas. The other thing you've highlighted quite nicely is also not just the impact of conflict, but also the economic downturns and inequities and inequalities, but also of climate change. So the discourse on emerging and re-emerging infectious diseases and climate change quite rightly is increasing, particularly for vector-borne diseases, particularly for antimicrobial resistance. But also when we start thinking about Mpox and zoonotic infections predominantly, but also ones that eventually spread from humans to humans, what we start to understand is the impacts, for example, of extremes of heat, deforestation, how people interact with their environment and with animals. And we don't know what spillovers we're going to see on the back of these different changes in climate, and how our populations who live perhaps more closely with nature, with animals in these settings, may find themselves. And I think the other aspect here is the importance of not just thinking about Mpox. It's one outbreak. It was an important outbreak affecting our population, but at the same time, MSF was responding to measles, cholera, increases in malaria as well, all of which are affected by conflict and displacement, all of which have important prevention aspects to them, whether it's by vaccination or vector control, and also all of them which disproportionately and negatively impact the health of children, particularly where there is food insecurity, particularly where health services for children are also interrupted in these settings. So I think your question at the end is, what can we do better? And I would say that there's a number of things. We started to touch on the different licensing and WHO approvals for these vaccines. So obviously now when we talk about pandemic preparedness, we're increasingly discussing these first 100 days of response. And what we do know, and we've discussed this a lot within MSF and the movement, is there was a slowness in the prioritization of children, and for that matter, pregnant women, in research and licensing for vaccine and other products, when we know that children under the age of 1 year old are particularly affected. And so what we need is emergency approvals around some of these unlicensed products where the benefit outweighs the need and where it can be life-saving in, for example, a high-risk contact child. And for example, that is what we had in some of the high-income settings. There were these approvals in place and there were these mechanisms to be able to respond in a timely manner. And I think many of you who've been following the conversations about the Independent Pandemic Preparedness Secretariat and their challenges and conversations will know is this is one of the things that they highlighted. And there may be a number of reasons for this. One of it may be a global health security argument. Another may be some of the challenges when you are dealing with vulnerable populations such as children in terms of these international mechanisms and some of these medicinal products. What is it that we can do better? I think my colleagues have already stated the very important things that we need to do as an international community, given the significant aid cuts, not just affecting vaccination, humanitarian responses, but also food. The World Food Programme has had significant cuts that are directly impacting our populations. In MSF, of the many things that we are doing that goes beyond advocacy is also enforcing the importance of prevention primarily and making sure that healthcare access is available appropriately and promptly for the populations that we serve, because of course, we'll use Mpox here for an example. If you wait until your disease becomes severe, it becomes harder to treat, harder to manage. Whereas if you had better healthcare access early, or better still, we're able to prevent it early, you're on a much better footing. There are other things that we need to do, and that includes supporting local ground-up initiatives, because we know of the many reasons that there needs to be localization. Localization is more cost-effective, it more directly reaches the population, and of course there's often better sustainability and trust, and of course that has important economic and financial implications. And lastly, we need to discuss important aspects globally around equitable access to vaccination. To give you an example, I work in the UK as an infectious diseases doctor, and I received 2 doses of vaccine in 2022 when we started to have cases in the UK. What I would really like to see is our healthcare worker colleagues, our colleagues working in the field, having that same level of equitable access, because you asked me about vulnerabilities and I stated some of the others, but our workforce and our healthcare workers, but also the people involved in cleaning and water sanitation, there are important people in the wider workforce in this response and potentially at great risk in terms of contamination with Mpox. And then I think the last thing I'd say here is the importance of improved collaboration, reducing redundancy where that is possible, to make sure that we're more cost effective and generally effective in the humanitarian responses, not just to Mpox, but some of the other emerging and re-emerging diseases that we're seeing around the world.
Great, thank you so much, Dr. Alada. My pre-made questions are, we're going to stop with that because we do have some time for some questions from the audience. The first question we received is for Professor Yap from Victor Umbala. Would using alternative samples that are pre-lesion forming something that can be implemented to mitigate transmission? Saliva or tongue swabs have been shown to have over 85% sensitivity among those with Mpox lesions. This can be an alternative to decentralized testing, especially using molecular point-of-care tests.
Yes, no, thank you. That's a very good feedback, because currently we are relying on collecting sample using swab on the skin of patients that have the rash, therefore the symptom, and we have to send them to the lab where we use point of care gene expert and others. So all alternative technology, either at the level of sample collection, at the level of sample transportation, and at the level of testing, because currently we are evaluating 2 rapid diagnostic tests, which should be able to provide us the answer to whether the patient has Mpox or not within 15 minutes. So we hope that this will also provide us some good result, therefore allowing the decentralization to go up to the community level. So I will urge the colleagues to reach out to us. Maybe Samantha will provide our email so that we have those information. We can transfer them to our research and laboratory pillar so that they can include them in the evaluation. You know, before proposing using some of those tests, we really need to ensure that they have been properly validated. But this is definitely an important tool into the decentralization of the laboratory. Thank you.
Thank you so much, Dr. Yap. The next question we have here is for Dr. Avara. Is there research underway to understand why younger children are so vulnerable to Mpox Clade II? This is important for malnutrition and other comorbidities.
So I think there's been studies that look at the different risks and risk factors which may put children under more vulnerability. If there's more in-depth immunological investigation, I'm not aware of it, and bearing in mind some of the challenges that we face in the DRC, it may not be possible to do some of those tests. We've certainly had discussions like this. For example, we did have a neonate in the UK early in the 2022 outbreak, and there were discussions about what we can do in terms of looking at immunological profiles and responses as to why neonates may be the most vulnerable. But I guess if you think about it, neonates are vulnerable to a lot of other viral infections, perhaps more so than some of the adult populations, and I'm sure there's a variety of reasons which relate to that. And of course, if they are malnourished or affected by co-infection with other diseases that affect their immune system, that might also put them at risk. But I'm not aware of more in-depth research around that. But I don't know if Professor Yap or Mr. Noda are aware if any of these studies are ongoing.
Did either of you have any idea about that as well? No. Okay, great. Thank you so much, Dr. Avara. The next question is for Mr. Kipchidze. From Jared Schulten, is the age range you mentioned, 18 to 49 years old, most affected due to greater likelihood of sexual activity, or is there some other hypothesis or evidence for this? Some older cohorts had smallpox vaccinations in the USA, for example.
Yeah, it's a great question. So if we think to the 2024 outbreak in terms of the adult populations that are affected, I think it's really multifaceted. You know, obviously sexual transmission is playing a role, but it's also just kind of close contacts. So as Dr. Ibarra had mentioned before, you have huge swaths of internally displaced populations, and so they're in very tight spaces where it just really facilitates transmission of Mpox as well as just other infectious diseases, both bacterial and viral. And so I think it just is an unfortunate situation. You know, these pathogens usually take take hold of these unfortunate situations to really transmit quite effectively. And so really in terms of, you know, what or why that age range, again, I think it's just very multifaceted in terms of the modes of transmission.
Thank you so much.
Maybe Samantha, if you don't mind, I would like to add some few addition looking at what we are seeing across the continent, and rightly so. It was mentioned the issue of the transmission, but here we start by the clade. We have the clade 1A and the clade 1B. The original one was the clade 1A, which was a spillover from the animal to the human. And we were seeing a household transmission, so within the families, and therefore the children were affected. So now we have some evidence of sexual transmission of the clade 1A. So we move from animal to human to household and now to sexual transmission of the clade 1A. Now for the clade 1B, we are seeing the opposite, where initially in countries like Uganda, where we see an increased number of cases and exponential increase due mainly to the sexual transmission, focusing on population, the sex workers, the truck drivers, and so on. But now what we are also seeing is that we have the household transmission of the clade 1B. So just to say that all those things are dynamic. We start from one way of transmission, one population. If it's sexual transmission, we are mainly talking about the adult, but then when it comes to the household, that's when the children are exposed. But maybe the thing that I also want to highlight, which is also an advocacy piece, is that DRC is the only country where the vaccination is approved with the MVABN for children between 1 year and 12. All the other countries are starting from 12 and beyond, while we are seeing those children affected. So it's important to take the opportunity of those platforms to encourage country, one, because the children are also affected, two, because we see in DRC that we don't have a severe adverse event in children. So the vaccine is pretty safe in that population. So it's important to have to consider that so that we ensure that everyone is protected and no one is left behind, especially because of the age.
Thank you so much, Professor Yap. We have another question actually here for you. I believe that's asking if there's any progress with point of care testing, RDT, on the ground.
Yes, there are lots of progress. I remember I mentioned that the plan we are into now, the response plan number 2.0, is focusing on the intensification, where we really want to catch all the cases wherever they are, scale up the vaccination and increase the surveillance, the IPC and case management. And the second part is the integration. The integration, I think it's Ala was talking about it, in an eastern part of DRC. You have measles, you have Mpox, and it's not possible clinically to make the distinction between the two. So what we've been pushing is the evaluation and therefore the validation of point of care that can make the distinction between Mpox, measles, and chickenpox. So that when we have the patient, we can take care of them according to what they have in terms of testing, but also in terms of management. The way we manage the IPC, the case management, and also the vaccination will differ depending on that. So this is the first advance in the point of care. It's really to have those multiplex testing that are being rolled out in the DRC, and that will continue to be rolled out in other countries. And the second one I mentioned, ongoing the validation of the rapid diagnostic test, and based on the result, we will be able or not to use them in the field.
Great, thank you so much. We have one question. It hasn't been directed to anyone, but it says, in Nigeria, mode of transmission has been largely human to human. Has there been any big break on animal to human transmission in the African continent?
Yes, if I may start, in Central African Republic, for example, we've been having a case, Mpox has been around. We've been seeing an increased number of cases last year and early this year, 2025. And this one, based on the genomic surveys that we've done, are mainly spillover from the animal to human. So this is really one of the places. Also in DRC, when you go to the province of Equator and some of those provinces also close to CAR, that where we keep on seeing the transmission from human to animal. This highlights the importance of the One Health approach. And this emphasized the fact that in the target, I was talking about decentralization, for example, in the target of lab that need to be supported, the vet lab are also part, so that once the surveillance is done, we can also track to see which are the animals that are responsible of the transmission. There has been an article months ago from Ivory Coast in partnership with the Helmholtz Foundation in Germany, where they find a new reservoir for Mpox, the squirrel, which is an animal that is, one, being used by children to play with, and two, by other villagers to eat. So those are important findings. Just to highlight that the Mpox is really in need to have a One Health approach. The animal, the human, but also the environmental, because we are now tracking Mpox in wastewater, so that where the human surveillance is lacking, we can be in the position with the INRB to track those viruses in the wastewater. And this is something that is also working pretty well.
Thank you so much, Professor Yap. One last question for Dr. Avara. How is the current Mpox outbreak impacting the emergence and spread of antimicrobial resistance in the region? Can you speak a little bit about that?
Yeah, so in the Mpox Treatment Centre in Uvira with MSF Amsterdam, we've started to ensure that we address this issue. So, for example, this Mpox outbreak may be associated with overuse or misuse of antimicrobials, which can be an important driver of antimicrobial resistance. There may be a tendency, particularly if there's severe Mpox lesions, and we've sadly seen this practice in a number of different settings with people affected by Mpox, where almost people might choose to have a lower threshold for starting antimicrobials or starting intravenous antimicrobials. So or maybe giving a longer course than they otherwise would. And all of this could be associated with the development of antimicrobial resistance. Again, with the Mpox outbreak and the complications that we see as clinicians, some of which are rare, some of which are more common, the most common probably being skin and soft tissue infections, including necrotic infections, where it may well be reasonable if there's suspicion of superadded bacterial infection to also start antimicrobials. That could be a driver of AMR. And of course, some patients may get other complications like pneumonia, meningoencephalitis, and other such complications where antimicrobials may be used or misused in different settings. The extent of this we may not know because, like we said, with the disruption related to the conflict, we may not have the full extent, and with microbiology services, for example, not being as available in many of these settings, we may not know the extent of AMR. And then the other important factor here relates to the interrelatedness and the sort of the very close relationship between not just AMR and environment, but also AMR and climate change, AMR and conflict-affected settings, where you may see multiple drivers in this particular setting, even going beyond Mpox, which can also drive antimicrobial resistance and may also lead to increased transmission that we may not fully be able to ascertain in such settings.
Thank you so much, Dr. Avara. I want to make sure that we close this on time, but before we officially close the conversation, I wanted to invite any of you speakers to let us know any take-home message you'd like the audience to have in regards to the current outbreaks and response and what to keep in mind going home.
You can start.
Yes, of course, Dr.
Yes, so no, thank you so much for holding this webinar. The take-home message is that the Mpox outbreak is continuing in the African continent, but because we are interdependent, whether we are talking about the funding, whether we are talking about the spread of disease, we all need to invest on the response to this outbreak. We are in the intensification phase, looking for integration and for the legacy. we really want the countries affected to be different after the outbreak than before, with the capacity to decentralize the laboratory, the surveillance, and of course, the scale up of vaccination that will rely on the solidarity, because vaccination is an issue of equity. So we really hope that we'll manage to get the dose that are needed, and with the support with all the partners, MSF, UNICEF, and all those, will be able to bend the curve so that we can move to something else. Over.
Yeah, I would just like to thank you, Sam, again for putting this all together, and for my fellow speakers. It's really great to hear from both of you as well to get your perspectives on the situation. I think for me, the take-home message is just the reminder of really using a One Health framework in terms of just thinking about public health. If we think about emerging and re-emerging infectious diseases, about 70–75% are zoonotic in origin, and thinking about what are the risk factors for those spillover events to occur, thinking about things like animal reservoirs and all the other factors that kind of drive, largely human-driven factors that drive these spillover events to occur more and more often, things like land use change, climate change. All of these are things that are being done by humans. And so thinking about how can we maybe modify some of those behaviors, whether through policy or just real buy-in from other governments and administrations, and really just using that One Health framework to potentially prevent the next pandemic. And then I think secondly, as Professor Gap had already mentioned, really thinking about the equitable distribution of vaccines. As my background says, vaccines save lives. It's not just for Mpox, it's not just for COVID either. There are many other vaccine preventable diseases out there, and vaccine distribution and access still is very much an issue. And so thinking about how can we really be distributing those vaccines in an equitable way globally.
And so I would say among the most important things going beyond the One Health approach is making sure that we always address these issues beyond the pure biomedical and really take a transdisciplinary approach across sort of anthropologists, across water and sanitation experts, and of course the healthcare workers and the wider team of healthcare workers and thinkers in this space. And secondly, prevention is always better than cure. So that's vaccination, but also the community and public health messaging that we need to enforce to support our often vulnerable communities, and also to go out and reach them where they are rather than expect them to come and find us with these different things. And I think the last thing to say, and it touches on what Professor Yap has said, is taking a system strengthening approach, because we must never just look at one infectious disease on its own. They all have reverberating effects across a spectrum, and not just in infectious diseases, but also beyond that, for example, in maternity and pediatric and childcare and non-communicable diseases in these settings. So really trying to be holistic in how we understand and approach these outbreaks, because very sadly, it's not just the current Mpox outbreak we're seeing, not current just increases in malaria, measles outbreaks, cholera outbreaks. Very sadly, we may well see other spillover events which can affect often the most vulnerable communities that we serve.
Thank you so much, everyone, again for joining us. It was an honor to gather all of you today and to hear your thoughts and learn from your experiences. We really hope that what's been said today will carry over and we can continue discussions and talking about this in the future and for change and for better outcomes, right? Thank you very much, everyone, for joining us. Be sure to follow the One Health Trust for updates, and we'll have this recording up soon. Thank you very much, Professor Yap, Dr. Ovada, and Mr. Kipchidze for joining us.
Thank you so much.